First of all, I want to thank EHA and the media for the interest in our work. I'm presenting on behalf of the EuroSki collaborators, and EuroSki is Europe Stop Tyrosine Kinase Inhibitors in chronic myeloid leukemia. And the title, as you see here, and this will be presented this afternoon in the Presidential Symposium, is Stopping Tyrosine Kinase Inhibitors in a Very Large Cohort of European Chronic Myeloid Leukemia Patients, Results of the EuroSki Trial. And the background is that the introduction of imatinib, the first tyrosine kinase inhibitor, has substantially improved survival in patients with chronic myeloid leukemia in chronic phase. And this was around right after year 2000. And TKI therapy has then in clinical practice been instituted in most patients, but it has mostly been considered lifelong. However, there are some small clinical trials that previously shown that imatinib can be stopped in sustained deep molecular response. And between 40 to 60% of these patients maintain the molecular response even after stopping. So the purpose of the current trial was to determine the proportion of patients remaining in molecular remission after stopping TKI therapy in a larger setting, in a larger decentralized setting, and also to determine the predictive factors that will be able for you to determine beforehand how long a patient should be treated, and also how successful a discontinuation attempt will be in the individual patient. So in total, 868 patients were registered in this trial in 11 European countries. And they were chronic myeloid leukemia patients in chronic phase. And as a prerequisite before entering the trial, they had to have at least 3 years of TKI therapy and also been in deep molecular remission, what we call MR4, corresponding to 0.01% BCR-ABL copies on the international scale. And they had to be in MR4 for at least 1 year prior to study entry. And only patients who had not failed on any TKI therapy were included, so not patients that had been on multiple lines of therapy. So this shows you the outline of the study, and up here you see once again to the left TKI treatment for at least 3 years, and MR4, a very good therapy response for 1 year. Then they entered a screening phase after signing informed consent, where MR4 was validated in one of 6 central labs. And if this could be done, MR4 verified, therapy was then stopped, and the patients followed every 4 weeks for 6 months, every 6 weeks thereafter, and then from year 2 or 3, they were followed every 3 months. And if they had, at any of these times during this follow-up, a relapse defined as loss of MMR, then they were restarted on therapy. So the results are that with a median follow-up of 10 months, 62% of the patients still were in deep molecular remission after 6 months of therapy. And at 12 months, this number was 56%. We tried to correlate this to gender, age, or risk score, but neither one of those factors showed a significant association with the success of stopping of TKI therapy. However, longer duration of TKI therapy and longer duration of molecular response, MR4, prior to TKI stop correlated to a higher probability of successful stopping. So, and the cutoff, we have identified a cutoff suitable for imatinib therapy that is around 6 years. So with a minimal p-value approach, about 6 years of therapy would be optimal for therapy prior to performing a stop attempt. So the conclusions are, with inclusion and relapse criteria less strict than in many previous TKI cessation trials, and with decentralized but standardized disease monitoring, stopping TKI therapy in a large cohort of CML patients with a very good therapy response was feasible and safe. The impact on the quality of life for patients and the savings in treatment costs for the European healthcare systems will be analyzed in more detail. So thank you very much.